Thank you,
Okay.
Dr. Yakovo. I don't know if Dr. Spargias wants to say a few words about our new valve.
Kyriakos, you can do that.
Okay. So we were really honored to treat the first patients in Europe with the new platform of the Edwards valve, the Resilia valve, and we had a great outcomes for those patients. The Resilia valve has a new technology, a tissue that enables the dry storage of the valve, and it is also calcium blocking technology. Also the innovative is that we have at the bigger dimensions, the 29 millimeters, we have an ultra. The ultra technology also a skirt that we also took advantage, and we will see for next patient that we are going to present. Here we see the innovative tissue technology of Resilia, leading to 72% lower calcium content. And this is a state-of-the-art new publication showing that with Resilia we have achieved lower mean gradients, also better hemodynamics. So we'll proceed with our case, 85-year-old male. We would like to also to see in the background the case maybe as live in the box. If it is possible. So 85-year-old male patient, BMI for 26.8, short of breath on exertion, especially in the last 4 months, NIHA stadium 2 to 3. In the transthoracic echo, a severe aortic stenosis. We see the numbers, LV ejection fraction of 40%, dilated in hypertrophic LV with impressive diameters. Also a dilated aorta with 45 millimeters, a moderate to severe TR with possible pacemaker electrode involvement, a mild MR and RVSP for 23 millimeters. Medical history, permanent pacemaker, hypertonus, and problems with thyroid. We see his medication. The Euroscore 2 was 9.16%. Is it possible to, yeah, okay, thank you. So, it is important to, as I said, to notice that the Resilia valve has a dry tissue storage, so we need only 2 minutes to place the valve in the water infusion and it is ready. We don't need longer preparation. Beginning the intervention, we used 2 prog lights, one at 10 o'clock and one at 2 o'clock, before introducing our sheath. We see a severe stenosis, I said, with a Vmax for 4.23 meters per second. Here's the ECG of the patient and the X-ray. We see the leads in proper position of the pacemaker. CT, heavily calcified bicuspid valve, probably of type 0. And we see also a calcium region diving in the direction of the mitral valve, which should we take care of. In the live in the box case, we see, as I mentioned before, the dry storage tissue of the valve. It needs 2 minutes, as we said, to place it in the water. So this is the innovation. Moving on with our case, we see the heavily calcified bicuspid aortic valve with a large annulus, the diameter 31 to 35 millimeters, and an area for 8.97 square centimeters. Maybe we should ask the colleagues now what would be their thoughts. We have a bicuspid valve, heavily calcified with a very large annulus.
Discussion. So I didn't see. So the LVOT measurement was.
That's coming. Yeah. Sorry. So this is a supraannular measurement, 4 millimeters from the annulus, and 7. See a diameter from 38 millimeters. And I don't know if we have. No, that's all that we have from our CT measurements.
So when you're dealing with a bicuspid valve, you always look for what kind of bicuspid is, and also you look for the LVOT, if it's tapered, non-tapered. So all this information will help you guide the procedure. So Michali, how do you normally approach these patients?
Yeah, indeed, it looks like I got type 0 with a lot of calcium on the leaflets and severe stenosis. Definitely challenging anatomy and fairly big annulus. As we saw, it's over 800 millimeters square. So technically speaking, what one could think from the get-go about implanting a large valve, either one of the very large MyVal 30.5 or 32 to consider that, or a Sapien, the Resilia Ultra 29 with a lot of plus on the balloon. But I'm not sure about the Evolut 34 in this case. I think it was also horizontal anatomy, and there was also other issues that were against an Evolut valve. But definitely in all bicuspid valves, we tend to do a pre-dilatation that will always give us a hint about the degree of stenosis and how well this valve will behave during actual valve deployment. So I think balloon pre-dilatation in this case would be very important.
I think that's of paramount importance to do a pre-dilatation with the nominal balloon and according to 12 VOT measurement, maybe undersized a little bit, but yeah.
We were indeed between two valves, the MyValve and the Resilia valve. Maybe we could use the new innovation of the skirt in the bigger diameter, and we decided to do a valvuloplasty, and according to the outcome, we would decide also the type of the valve that we were going to implant. So moving forward, the coronaries of the patient didn't show something crucial. The axis, the peripheral axis, was also feasible. See the right side, and we see the heavy calcified aortic valve, and we also see a mild to moderate regurgitation. We wanted initially to place a sentinel protection, but due to anatomical reasons, there is also calcified. We decided that it was not in the favor of the patient. We check also the pigtail position before placing our extra stiff, the Safari wire, and now we see the valvuloplasty. It is a 25 millimeter balloon of Edwards. We see the sealing of the valve, which enables us to think about using the 29 millimeter Resilia valve. And we should also bear in mind that it is a bicuspid valve. So although the measurements of the very big annulus, due to these aforesaid factors, we were thinking about using the Resilia 29 millimeters valve. I don't know if Dr. Spargias has a comment.
That was the decisive moment of the procedure where the decision was made about what valve we're going to use. We had available all the valves, and if we stuck to the CT scan information, that would be my valve, probably the very large one, the 32.5, according to the CT data. Clearly, the perimeter was too large, more than 100 millimeters for any self-expandable valve. But because of the bicuspid anatomy, and especially the type 0 bicuspid anatomy with a lot of calcium, and from our previous experience, we knew that such anatomy is very likely to prove to be sealed by much smaller balloon expandable valves. And this is exactly what happened here. So this is a 25 millimeter balloon, and you can see it offers complete sealing. You don't see any contrast going back to the ventricle, which means that the 29 millimeter Resilia valve with the sked will be super sufficient to do the job. If someone was going blindly, according to the CT scan with a 32.5 my valve, I think the effect will be catastrophic.
Also, we could comment maybe that there is some proximity of the leaflet, the severely calcified leaflet towards the left coronary sinus and towards the left main. Essentially, it fills the whole sinus of Valsalva. There is good flow over it into the left main, but again, this 25 millimeter balloon seems to be very adequate in terms of sealing the valve.
So 29 is the way to go in this case. Maybe 34 Evolut would be sufficient as well. Probably in our center we would use an Evolut 34, but yeah.
About the proximity of the left main, yes. Michael commented earlier. I think this is a 2D imaging that is misleading us, because on the CT scan imaging, the planning, the distance from the left main to the other side of the sinus of Valsalva was like 36 or 38.
Yeah.
So I think it's the 2D imaging that is a little misleading us here.
Good.
That was the case. We also did a lot of different projections to be sure that there was adequate distance to the left main. As Dr. Spargias said, we had also this very important information from the CT. So we have here placed our valve in position. We've pulled the pigtail, and we are ready for the valve implantation. Under rapid pacing was a 29 millimeter Edwards Resilia valve, minus 4 ml.
It was plus 2 on the balloon.
Sorry, plus 2, yeah, plus 2. And we check the outcome. We see that the valve was not optimally expanded. Since it was also a very big annulus, we wanted the maximum expansion of the valve. So we decided to proceed with the post-dilation. We put another 2 millimeters. So it was a total sum of plus 4 in this post-dilation under rapid pacing. And this is our final result. The access point remained very good. And we ended, as Resilia platform says, with a very low mean gradient, a good hemodynamic result.
So I think that this is an excellent demonstration of how to treat a bicuspid valve with such large anatomy. So this is very tricky. The valve is also a little bit horizontally. I think that this was a great demonstration with a new valve. So basically, it's the same ultra device. So the skirt is the same. So you don't worry about more frequent pacemaker implantation. Of course, this is not the case in this case. But yeah. So you have the same practice as the previous ultra, right?
Essentially, yes. The platform is the same. Loading of the valve on the device, everything is the same. And the implantation technique is the same exactly. We don't have any. The major difference is, number one, the Resilia treatment of the tip of the leaflets, and the way the leaflets are sutured on the frame. It actually allows for a bigger valve orifice, which is very important for smaller sizes, obviously, not so much for the 29, but it's an important consideration as well.
So, so if you have a Resilia Ultra, it's purportedly it has the same durability as the Resilia surgical implanted valves. You think? So I don't have any knowledge on this issue. Maybe Dr. Riardon can make a comment on that. So, is the durability-wise is the same?
No, we don't know. I mean, so far it looks really good, but the 7-year data from the COMMENCE trial was reported a year ago at the AATS, and so we really are only up to 7 years on Resilia. You know, the 7-year data is coming out on the Valus valve, the 2 new pericardial valves. But until we get to 10 years, we don't really know. It looks very good at 7 years, but again, we don't know. We'll see in a couple years if it's going to hold up. But so far, the data is very encouraging. To me, the most encouraging thing is I like the way they redesigned the way they put their commissure post on there, and it allows it a bigger opening. I think that's an improvement.
Okay, this is excellent. I think, Mike, we can proceed on the next case. So thank you, Dr. Katsianos.
Thank you very much.
So the next case will be presented by Dr. Stathogiannis.